Thank you for attending Dr. Hoffman's Regenerative Medicine webinar. We are thrilled to have you here with us this evening and are excited to introduce you to this very popular topic. We hope you will walk away feeling fully informed and will be glad to answer questions at the end of the presentation.
Our practice is overall focused on total concierge care for our patients. We look at the entire diagnosis and prognosis of each injury that comes into the office. By offering a total concierge care, that means that surgery may not always be the best option for treatment of your condition. That's where regenerative medicine comes into play in terms of offering other options and other opinions in terms of treatment options to treat pain, number one, but also restore function, number two. So, as questions that we ask ourselves as surgeons, number one, what are the other options if conservative treatment fails? And there are a number of different conservative treatments, including physical therapy, bracing of various kinds. These options are useful for most procedures and most diagnoses, but every so often they do fail, and we have to find another option and another way to treat these conditions. So as surgeons, we look at surgery as certainly a viable option. But again, regenerative medicine is now entering into our field in order to give us another option to treat some of these conditions. In some cases, patients may not be ready to have surgery. They may be from a social standpoint or from a timing standpoint, or certainly from a worldwide pandemic standpoint, they may not be ready to proceed with a surgical procedure. And these injections and procedures do offer us some incentive and in terms of pain relief, as well as treating patients to get them through to their surgery, and in some cases actually prevent them from having a surgery done in the first place. All right, next slide. So in general, these are the topics that we're going to cover tonight. The first and foremost is a platelet-rich plasma or PRP injection. The second is a bone marrow aspirate concentrate injection. There are other types of regenerative medicine procedures that one of our panelists will discuss tonight as well. And these include amnion or placental tissue injections, as well as stem cell injections and procedures taken from adipose tissue. So currently we are most focused on our PRP and our BMAC injections. Therefore, that's going to be the main topic of our presentation this evening. Next slide, please. So we have a nationally renowned panel of speakers for you this evening. You can see as myself, I'm again a board certified fellowship trained orthopedic surgeon. I'm fellowship trained in foot and ankle surgery primarily. I participate in a number of lower extremity trauma surgeries as well. I did my training locally at Tufts Medical Center and my fellowship at the next up will be Christine Schrader. She's been involved in this type of work for 10 to 15 years. She has some personal experience that she's going to share with us as well as her current work capacity and the benefits that she has found from these regenerative medicine injections. Following her will be Dr. Kai Mithofer, another member of the Boston Sports and Shoulder Center practice. Again, he is a board certified fellowship trained orthopedic surgeon and primarily focusing on sports surgery and surgery of the shoulder and knee. Also did his training locally at the Harvard MGH program and did a fellowship at the Hospital for Special Surgery. And our final speaker today will be Jason Rand, who many of you know very well. He has been a part of our practice for over a decade as well. He is the first assistant for Dr. Brian McKeon. And he has lectured nationwide on intra-articular injections and therapies and has a great skill set in terms of ultrasound techniques for localizing these injections to the appropriate structures. So that is our panel. I'm now going to turn it over to Christine Schrader. So she's going to give us our initial foray into the biologics of regenerative medicine, some basic science here to set the table, and then we'll transition to more specific applications within the field of orthopedic surgery.
Thank you so much, Dr. Hoffman. And thank you all for joining us tonight. I echo Dr. Hoffman in saying that we are so humbled and excited that you are so willing to jump on a webinar this evening to learn more about. Again, if I can just remind everybody to please stay muted during the presentation so that everybody can hear. Otherwise, we end up with a lot of background noise. Throughout the presentation, hopefully most of your questions will be answered, and we will go through some of the most frequently asked questions in regenerative medicine at the end of the presentation, and then we'll have time to take some of the questions that you're posting in the chat room. So you may want to wait until we get through this presentation to put up your questions in the chat room, because we might be able to answer those as the presentation goes on. So again, just introducing myself, I'm Christine Schrader, and I'm a physician assistant. Clinically, my past experience has been in heart surgery, women's health care, and hematology oncology, which is taking care of cancer patients. But for the past 15 years, I've had the opportunity to work in the regenerative medicine specialty. And I've had the great privilege of working with physicians across the country, as well as internationally, in this space. And I am really passionate about this specialty in medicine, not only because of the amazing benefit and outcomes that I've seen patients get from these treatments, but also, as Dr. Hoffman mentioned, my own personal treatment, or my own personal experience in having these treatments, both in my neck and my knee. And I'll talk a little bit more in detail about that a little bit later in my portion of the presentation. But what I want to do in my portion, again, as Dr. Hoffman mentioned, is just go through some of the science to help you better understand how biologics really play a significant role in tissue healing and tissue regeneration. So I want to start out with the definition of regenerative medicine. And that is, this is the process of replacing or regenerating human cells, tissues, to help restore or establish normal function. The central focus, as Dr. Hoffman mentioned as well, is going to be on human cells. And it's really the focus in regenerative medicine. There are two types of human cells. There are cells that come from your own body, which means autologous. So we'll use the word autologous, and that just means using your own cells, your own healing and regenerative cells. And those products are called platelet-rich plasma and stem cells from concentrated bone marrow aspirate. And then there is also donor human cells or products that come into play in the regenerative space that are growth factors and cells from donor type tissue that actually come from placental type tissue. So these are donor tissues. Again, our focus today is going to be on autologous cells and the role that these cells play in tissue healing and regeneration. So go on to the next slide, please. If everybody could stay muted other than myself, that would be great. So there is a hypothesis for autologous therapies. Again, autologous meaning from you, for you. And that is that we know that the human body has built-in repair mechanisms, namely stem cells and platelet growth factors and white blood cells that help it to recover from tissue injury. So the idea is that by harvesting those healing and regenerative cells, concentrating them, and delivering them back to an injured tissue site may actually accelerate the overall repair process and improve tissue function and quality. So in the picture below, what is bone marrow being aspirated? And most often this happens in the backside of the pelvic bone, which is called the posterior iliac crest. It's the site in our bodies that has the largest volume or contains the largest volume of bone marrow. Once it's harvested, it gets concentrated. The cells that we're looking for get concentrated in a special device. And then that final product gets delivered or injected into the injured tissue site. So that's what you're seeing in those pictures below. Next slide, please. Okay, so as far as requirements for regeneration, there are 3 components that are required. And to help you better understand those components, I like to use a garden analogy. So in a garden, we need to have 3 components, being seeds, fertilizer, and soil or a trellis for that garden or that plant to grow in or upon. So in this garden analogy, the seeds are the stem cells that come from bone marrow aspirate. And the reason we consider these seeds is because stem cells have the ability to replicate themselves over a period of time and then eventually change into whatever tissue type is needed. And again, in our garden analogy, we need fertilizer. And growth factors and signaling proteins that get released from platelets or white blood cells actually act as fertilizer in our bodies to help the stem cells function in tissue healing and regeneration. Okay, so we have fertilizer, which are the growth factors and signaling proteins that come from platelets and white cells. And this is what we get when we use platelet-rich plasma. And so when platelet-rich plasma is injected, what happens is platelets release these growth factors or signals that call in all the cells necessary, namely the stem cells, to help tissues to heal and regenerate. And then finally, the soil or trellis in our bodies is actually the injected tissue that's damaged, as well as a fibrin matrix that gets formed from the plasma. So we can go on to the next slide. So again, we talk about cells, signals, and scaffold, the three components needed. The cells, again, which are the seeds, come from bone marrow in the form of concentrated bone marrow aspirate. The signals, again, come from growth factors, from platelets and white blood cells, and that's what we have in our platelet-rich plasma. And then finally, when we process either peripheral blood or bone marrow aspirate, that final product comes delivered in a volume of plasma. And what happens when you inject plasma is the fibrinogen in plasma converts to fibrin, and you end up getting this three-dimensional sort of fibrin matrix that you see in that last slide there that forms at the injured tissue site. So that becomes a very nice matrix or scaffold to begin the tissue healing and regeneration process upon. Okay, go to the next slide. Now, there are other benefits to using concentrated bone marrow aspirate besides just the fact that it contains stem cells. And whether the physician chooses to use bone marrow or PRP is up to their discretion. But I will say that oftentimes in areas of the body that don't get a lot of blood supply, like the joint or the disc, they tend to go with concentrated bone marrow because stem cells tend to function and thrive very well in areas that don't get a lot of blood supply, but platelets not so much. Now they can still function fairly well, but oftentimes we tend to go to bone marrow. And there's really two reasons, not just because stem cells can thrive better in that environment, but also because bone marrow contains a protein called IRAP. This is interleukin receptor antagonist protein, and this is a natural anti-inflammatory. So in bone marrow concentrate, what we know is that the level of IRAP actually gets concentrated as well. And what IRAP does is it binds to the inflammatory mediators, or what we call interleukins, in the joint space to help stop the progression of cartilage degradation or degeneration. So it halts that whole degenerating process, but it also blocks the inflammatory interleukins that cause pain. So oftentimes we see people getting some really good pain relief when bone marrow is injected into the joint. Next slide. This is just really a simplistic picture of everything I just talked about to tie it all together and how our bodies heal naturally using these cells and proteins. So as you can see in the very first picture there, you can see this sort of fibrin matrix that's formed at an injured tissue site. So I use the example of a torn muscle. What happens is platelets get rushed into that area, the fibrin matrix begins to form, and the platelets release the signals, or those growth factors, that go out into the body and call in everything necessary to heal and repair that tissue, mainly the stem cells. And those stem cells tend to be very sticky, so they adhere very well to that fibrin matrix. Those same growth factors, or that fertilizer, if you will, then causes those stem cells to begin to replicate or multiply themselves over a period of days. So you end up with many more stem cells adhered to that matrix than we first started with. And eventually, again, that fertilizer, those signaling proteins, will cause the stem cells to begin to differentiate or change into whatever tissue type they're attached to. So that, again, is a very simplistic picture of how our bodies heal themselves naturally. So again, the idea is to inject or harvest those healing and regenerative cells, concentrate them, and inject them right where they need to go and do their job. Next slide, please. So there's some myths out there regarding regenerative medicine and some of the therapies that are being done. And I wanted to just touch base on some of these. There's been some seminars on stem cells, a big buzzword these days. And what a lot of patients are being told is that if you're over 50, you have no stem cells. And this is simply not true. As long as you're alive and breathing, you have stem cells. If you didn't, you wouldn't be here. And so stem cells, while they diminish in numbers as we age, and to some extent how they function, they are still present, and they still have some ability to function as we age. Another myth that we hear is that bone marrow harvesting is too invasive or painful. There is a special way to do this procedure in an office setting that makes it very tolerable to patients, and that involves some really good localized numbing. And I'll speak to my experience as well, that I've had bone marrow harvested a couple of times now. I've had arthritis in my facet joints in my neck, as well as a meniscal tear in my knee. both, I've had one treated with bone marrow, which was in my neck. And the bone marrow aspiration, I have to say, was very well tolerated. Oftentimes practices will offer some medication just to help you relax a little bit. I didn't take anything because I really wanted to understand how my patients felt. When I work in a regenerative medicine practice and I harvest between 5 and 10 bone marrows a day, and most of those patients don't require any sort of relaxing medication. And I wanted to understand how that felt. And so I will say that I tolerated it very well. I had a little bit of a crampy sensation for a couple of minutes, but that went away as soon as the draw was finished. So from start to finish, from the harvest to the injection, the whole process went very smoothly and was very well tolerated. So it is something that's quite simple to do. And oftentimes people are concerned about how that site is going to feel after the treatment. And I'll say that most patients don't even complain of pain at the bone marrow aspiration harvest site. They may have a little bruisey sensation for a week or two, but that's about it. So you heal from that very quickly. Another myth is that there's no data to support these procedures. And in the slide following, I'll just show you some of the procedures that we have a lot of data on, especially in the musculoskeletal world with using platelet-rich plasma and concentrated bone marrow aspirate. So there is absolutely very good data to show safety and efficacy with these procedures. And again, is it dangerous to harvest bone marrow? I think this question comes up because people are concerned that once we take it out, isn't that something that their body needs? And are we diminishing their bone marrow content? And it's not true. We can harvest, the amount of bone marrow we harvest is fairly small in terms of the volume, but the body will replenish that or replace that within 3 months. So we're not going to take anything out that's not going to be replenished. Okay, go on to the next slide, please. So again, I'm just showing you some of the different applications in the musculoskeletal world for both bone marrow aspirate concentrate or BMAC and PRP applications that is supported by literature, meaning there's multiple studies around these applications. And that is arthritis of the hip, as well as soft tissue injury, and even SI joint pain or the sacroiliac joint, osteoarthritis or arthritis in the knee, meniscal tear and other soft tissue injury around the knee. In the foot and ankle, osteoarthritis, obviously, fracture repair, Achilles tendinopathy, plantar fasciitis, and Charcot foot. In the shoulder, and I know Jason will touch on this, but labral injury, rotator cuff tear, and osteoarthritis as well. And in the elbow, tennis elbow, golfer's elbow, as well as osteoarthritis and carpal tunnel syndrome. So as you can see, multiple different applications with lots of literature to support the safety and efficacy of utilizing these cells in a treatment setting. So I'm going to go ahead now and turn this slide over to the presentation over to Dr. Hoffman.
Terrific. Thank you, Christine. That was excellent. So at this point, we're going to take what we just learned and transition that into the multitude of orthopedic conditions that we can treat with these types of procedures. I'll go first, as my forte is obviously foot and ankle surgery. And this is a not complete, but general list of the conditions that I've had success treating with these types of injections. And that includes the bone marrow injections and the stem cell injections, as well as PRP injections as well. You can see here, this is a list of really the most common type of conditions that I treat from a foot and ankle surgeon perspective. Certainly, there are people with Achilles tendinopathy and peroneal and posterior tibial tendon tears. I treat cartilage defects in the ankle with this. I treat osteoarthritis. Certainly, plantar fasciitis is probably one of the most common things that people complain of, one of the most common diagnoses that I see. So there's a wide range of applications for these types of injections. Now, in that realm, these are injections to help prevent or avoid having a surgery. So I certainly operate on a lot of these conditions as well. But when I do operations for a lot of these conditions, I will use the bone marrow and the stem cells intraoperatively as well, as an adjunct to help people heal faster, number one, but also improve their function, number two. So this plays a role not only in the office setting, but also in the operative setting as well. Next slide, please. So in general, this is the sort of basic breakdown of how these procedures are performed in my practice. And again, this is relatively universal within the world of foot and ankle surgery. You'll hear from our other speakers in a few minutes regarding knee, shoulder, and elbow applications as well. So in general, for a PRP injection, it's an in-office procedure. There's no anesthesia needed. The whole procedure from start to finish, which includes the blood draw to the site of the injection with an ultrasound, takes about 30 to 45 minutes overall. Patients are relatively comfortable throughout the whole procedure. Again, pain is very limited, and it's not a specifically painful procedure at the time. There's a relatively rigorous post-procedure protocol that we use, and that includes some immobilization and physical therapy as a way to further help the injury heal. In terms of in the operating room, again, I mainly harvest the bone marrow from the iliac crest, whether from the anterior or posterior aspect. Again, since the patients are in the operating room, this is done while the patient is asleep, which makes them more comfortable. The incision itself is very small. It's covered with a waterproof dressing and is usually tolerated very well. Most of my patients have pain for a day, maybe two at the aspiration site, but usually it doesn't cause any long-lasting concerns, and it's not one of their major complaints when I see them back for their post-operative visits. So I know you guys don't take my word for all this. So I think as I see a lot of the questions come through in terms of what we can treat and obviously what the results are. So what I did was I asked a few of my patients to provide some testimonials in order to give you an idea of A, what we treat with these types of injections, and B, what their outcomes have been. So this is sort of a random sampling. We'll start with the next slide, please. I'll give you a little bit of a brief history for each of the patients. Obviously, you can read most of the text on your own, but it gives you their experience from a patient perspective in terms of the symptoms they were having beforehand, their experience with the injection itself, and their recovery afterwards. So this is a 67-year-old female who had a chronic peroneal tendon tear. In general, this caused some tendonitis as well, which caused pain over the lateral ankle. She had done a number of the conservative treatments that we had already talked about, including physical therapy and bracing, but continued to have pain and limitations of her activities of daily living, as well as her recreational activities. So she went forward with a PRP injection. Again, this is a pathology or diagnosis that normally would necessitate surgery after failure of conservative treatments. But you can see here she was successfully treated with a PRP injection and has gotten back to her full activities in about 5 months since her injection. Next slide, please. Okay, this is a similar patient, 65-year-old female with a posterior tibial tendon tear, which is one of the most common pathologies that I see. Tibial tendon pathology is very common throughout the US. It's associated with shoe wear, it's associated with flat feet. So it's something that we see very commonly, certainly in this age group. Again, patient had tried the number of conservative treatments. At the time, I was running out of options. I was not really interested in proceeding with surgery. So we proceeded with a PRP injection, and again, with physical therapy and appropriate treatment, it has had a wonderful outcome and has been back to more of her normal recreational activities. Next slide. Similarly, another 65-year-old female, this patient had Achilles tendinopathy and plantar fasciitis. Again, two common symptoms that I see together. They are related functionally, if not anatomically. This patient, interestingly, had a previous PRP injection on her opposite side several years ago and did very well with that. Once again, had tried the number of conservative treatments, was not interested in surgery secondary to a friend's experience, therefore elected to proceed with a PRP injection again, and again did very well and has been able to return to her normal activities. None of these first two patients had any side effects from their injection and all did very well in terms of their initial pain after the injection itself. Next slide. This is a little bit younger patient, 34-year-old male. He actually had a bilateral issue. So he had big toe OCD, which stands for osteochondral defect. So he had a chondral injury inside one of the joints of the big toe. Again, very young, active, healthy male, was limited in his recreational activities. We ended up doing a PRP injection into both toes at the same time. So it certainly can be done bilaterally. And he, again, went through the normal post-procedure protocol, including physical therapy. And once again, his range of motion has improved, and now he's back to his normal activities without any significant side effects. Okay, next slide, please. And here's the last testimony from my patients. This is a 43-year-old female who had a ligament tear on the bottom part of her foot near one of the small toe joints. This is, again, a very common finding that I see on exam. That's also noticed a lot in some of the MRIs that I obtain for patients. This can be a difficult situation to manage because it causes a lot of pain on the bottom part of the foot, causes pain with walking. People are limited with their activities. In general, for this partial ligament tear, I've found more success treating these with PRP injections. I find that the surgery for this procedure is not well tolerated. It causes a lot of stiffness in the joint, and certainly in someone who's young and active like this patient, I found that they do much better with a PRP injection. So again, did the PRP injection in the office, minimal pain afterwards, and she's been back now 100% and back to running and enjoying herself. Again, just a brief snapshot of my practice, my patients. Again, we've been doing a lot of these regenerative medicine injections of various kinds. These are just, again, a smattering of successful results that we've had, but it gives you an idea of what we can treat with these injections and also the overall outcomes that we are able to obtain. Okay. Now, with that, I will turn it over to one of my partners, Dr. Mithofer. He is going to join us and speak on regenerative medicine applications and injections for common orthopedic knee conditions. Dr. Mithofer.
Yeah, hi. Thanks very much, Dr. Hoffman. I appreciate it. Also being part of this excellent webinar. I'm also part of Boston Sports and Shoulder Center. I have been working in regenerative orthopedics for more than 15 years. Currently also the director of joint preservation at New England Baptist Hospital. Next slide, please. So I want to speak mostly about the knee because that's one of my areas of expertise. Regenerative medicine application in the knee also varies, and they are listed as you can see here. The most significant ones are certainly knee osteoarthritis, meniscal tears, and articular cartilage defects, but there's also applications for ligament tears, acutely particularly bone injuries such as fractures and osteonecrosis and tendon injuries. Next slide, please. Somebody keeps muting me, so I'm not sure. Please unmute me if you can watch that, please. Otherwise, I'll go in and out. So knee osteoarthritis is the most common joint disorder in the United States. So it's a significant problem. It's based on a chronic degeneration of the articular cartilage, and it's very prevalent. There's an increase in incidence, but even in younger patients in age 45 and older, it's seen in about 30% of the patients, while about 40% of the patients or adults over 60 years have arthritic changes. This results progressively in a disability in participating in work activities, athletic activities, and then also day-to-day activities. And the treatment options are still quite limited and oftentimes are not regenerative, but also can lead to further degeneration. So we have physical therapy, we have medications, anti-inflammatory medications, cortisone injections, which can be leading to further degeneration of the joint. And what oftentimes happens is we end up with a joint replacement after progression through these stages. And the next slide, please. And knee replacement is a very frequent procedure. About 600,000 knee replacements are performed in the United States every year. And it's generally a good and effective procedure, but there are definitely, as an invasive procedure, surgical risks and potential complications. There's a long and intense rehabilitation involved. And even though 80% do quite well, there are 20% of the patients who have persistent pain. One issue that's particularly a concern for younger patients with degeneration of the joint is the limited durability of the joint replacements, which wear out after 15, 20 years, then need to be redone. Next slide, please. So the approach from our side has been to preserve the joint and prevent a progression to a level that you need a joint replacement. And that is done in a natural way that stimulates the articular cartilage biology. And we've heard from Christine how to do that, but also at the same time reduce inflammation and reduce the degradation that happens with the typical process of osteoarthritis. And then there's also an approach that is more guided towards early treatment of injuries that are ultimately leading to arthritis. And I'll talk a little bit about that as well. The ultimate goal is to decrease the pain that the patient has, but also increase the activity and importantly, delay or even avoid a joint replacement. Next slide, please. So the first option we heard about from Christine and Dr. Hoffman is PRP. Certainly you're familiar with the procedure. For the knee, there was a myth that we talked about. There isn't significant amount of data. I think for the knee, there's the most available data in this area, and there's significant high level science at the high scientific level with randomized controlled studies comparing it to multiple other treatment options. And it's consistently in those studies has shown a reduction of pain, an increase in activity, and has demonstrated a higher durability in treatment, for example, in comparison to viscosupplementation and the gel shots that are oftentimes used for osteoarthritis as well. There's been evidence also that there is actually an increase in the joint space, but importantly, in a recent study, there's a 74% delay in knee replacement at a median of about 5 years. This does seem to have the effect that we're trying to achieve in making people more active, but also delaying the replacement. Next slide, please. Stem cells we talked about briefly, and again, stem cells, derived mesenchymal signaling cells, have multiple purposes in the joint when we're injecting it. And one is to stimulate the cartilage regeneration. There are multiple ways of doing that we heard about. And then there's the anti-inflammatory effect, which is also equally as important in reducing degeneration. And it also helps to recruit some of the own stem cells that are still contained in the inner lining of the joint, oftentimes to help repair and maintain the joint. In addition, there's a stimulatory effect on the inner lining of the joint to create some of the own endogenous hyaluronic acid that can be produced for the joint and oftentimes missing in osteoarthritis. Next slide, please. So the stem cell results, or BMAC results, in osteoarthritis are also very encouraging. The amount of data that's available for BMAC is certainly a little bit less than for PRP, but there's increasing high-level data available. And a recent meta-analysis looking at more than 2,000 patients injected with BMAC for osteoarthritis demonstrated a consistent finding of, again, reduction of pain, improvement of activity of the joint, and also improvement of cartilage quality. Next slide, please. So besides the injection strategies we've talked about, there, as I said, there's also a approach of preventing arthritis from developing, particularly with articular cartilage defects and meniscal tears being some major players causing and progressing to articular cartilage if they're injured. And finding regenerative approaches to repair them can also certainly be a preventative approach to joint preservation. So next slide, please. And the analogy I like to use is, what we have with the progression of articular cartilage changes in the joint. You start with a small defect, similar with a small pothole in the street, and then gradually, if you keep driving over it, the pothole gets bigger, and ultimately you'll see multiple potholes, and that leads to joint replacement. Cartilage defects have been a major factor leading to a 5-fold increase or risk for the need for joint replacement. So they're a major factor in the generation of osteoarthritis. Next slide, please. And so the treatment approach here is to reduce the articular cartilage degeneration. That can be done through a non-surgical therapy, again, in using PRP and BMAC injections that can strengthen, stimulate the articular cartilage biology to stay strong, so the small pothole doesn't become a bigger pothole. And that's the primary indication for the non-surgical treatments. And if you have a larger defect, like you see in the picture underneath, then there are surgical indications where you can actually successfully fill these defects up with a combination of the 3 components that Christine talked about: the cells, the growth factors, and the scaffolds. And you combine them and place them into the defect in the surgical procedure, and it can heal the defect and fill the defect back up. It's like filling the pothole, essentially. Next slide, please. I want to give an example of this. This is a patient who received the combined procedure of the BMAC PRP with a scaffold. He was a 49-year-old, very active tennis player. He had this, large lesion in his joint surface that was cleaned out. And then on the bottom picture, you can see the surgical fill with the components of the 3 components. And this patient went back to playing tennis. And the right side, you can see an MRI scan. It might be a little bit dark to see, but this is 5 years out. And you can see that there's a nice fill of articular cartilage tissue still in the defect that was repaired at 5 years out. And the patient still is continuing to do quite well. Next slide, please. So the other, besides articular cartilage, the other important joint component in the knee is the meniscus, and you're all familiar with it as a shock absorber, and it's very frequently injured. The treatment options are obviously non-operative and surgical. The goal is for preservation in general. There's more than 850,000 surgeries for the meniscus in the United States every year, and the majority of those are meniscus resection procedures. And it has been shown that that can, in a high percentage of cases, in 71% of the cases, lead to development of arthritic changes from the lack of the shock absorption and breakdown of the articular cartilage. And therefore, meniscal preservation has been increasingly become a more important component of joint preservation in the knee. Next slide, please. And the way to do that is, again, there's non-operative options as well as surgical options, particularly for degenerative tears, like I think Christine had when she had her procedure done. There's a possibility of injecting either PRP. You can try BMAC as well, but PRP is better studied. And these targeted injections that are done on ultrasound or with minimal arthroscopy can be very successful in reducing the need for subsequent surgical intervention for meniscal surgery by about 72%. So that's very encouraging in that area. But then there's also the traumatic tears and the large tears that have a pattern that causes a lot of interference with the joint motion, a lot of locking sensations. And those tears might need surgical repair. And the surgical approach here is very successful in reducing arthritis and has been shown to reduce arthritis development by about 50%. The procedure itself has some risk for failure. The risk for failure can be significantly reduced by adding PRP intraoperatively to the repair of the meniscus, and that's something we'll routinely do. Next slide, please. So those are the most common procedures and points that I wanted to make about the knee. Certainly in BSSC, we're very interested in shifting degeneration back towards regeneration, and you've heard some examples now about the knee as well as shoulder, as ankle. We're going to move on to the shoulder and elbow with Jason Rand. Looking forward to that as well. Thank you.
Excellent. Thank you, Dr. Midhofer. That was very informative. So a couple of quick things before we get to Jason Rand and we move up to the upper extremity. Number one, I'm loving the participation in the chat. I see all the questions coming in. Rest assured, we are collecting those on the back end. I will stay to answer as many of those as possible once we are done. Secondly, I just wanted to share that every patient case that's been presented here has been shared with permission, and we have their permission to share those with you to give a deeper insight into how these injections and procedures can be beneficial for you as a patient. Okay, so up next, we're going to move up to the upper extremity. I would like to introduce Jason Rand for further discussion of treatment of common shoulder and elbow conditions. Jason.
Hi, everybody. Thank you for joining. And we have over 500 participants in this presentation. It's such a popular topic, and we're happy to offer this to our patients. We are primarily a surgical practice, but surgery is not the answer. And every time a patient walks through the door, it's an honor to treat them, and we have to provide them with all the options: surgical, non-surgical, regenerative, biologic, and ways to avoid surgery. So if we can start the lecture here. There's a few ways of looking at PRP. What I did is I divided into interoffice use as well as surgical use. In the shoulder, partial rotator cuff tears, adhesive capsulitis, osteoarthritis, going to the elbow, epicondylitis, and in surgery to help facilitate healing. If we can go to the next slide. This is a picture on the right side of the screen of the rotator cuff along the horizontal worm-like structures, the biceps. And the rotator cuff, you could see red on one side and white on the other. And the white is that rotator cuff, and that's an area of very poor blood supply. And this is a reason why there are tears of the rotator cuff are common in part. Partial tears are common, and healing of the rotator cuff can be challenging. And what a great idea to add platelets, biological factors to facilitate the healing. Again, in pre-op to avoid surgery and inter-op to aid in healing. And this is a study that evaluated the use of platelets, PRP, for an injection of a partial tear versus cortisone. Many people out there listening, I'm sure, who've had cortisone injections, maybe multiple, for your rotator cuff. And maybe that's not always the answer for a partial tear. Maybe that doesn't facilitate healing. In fact, it doesn't. It's an anti-inflammatory. So if we have an injection that may produce healing, shouldn't we be using that? And in this study, they looked at 6 weeks and 12 months out from the surgery, comparing two of the injections, cortisone versus PRP, and found no difference in terms of pain relief at 12 months and earlier on at 6 weeks, showing that PRP may be just as good compared to cortisone in these patients. Next slide. This is a case of a 53-year-old male with failed physical therapy. We had him work on posture, we had him work on strengthening, and unfortunately did not respond. The MRI in the center picture here shows a partial tear. And what we did is we provided a cortisone injection. We provided a PRP injection as he declined cortisone, had no interest in cortisone, and had wonderful benefit. Here's a picture of our setup. We do all of our injections under ultrasound, which is a great way of visualizing the needle. For this to work, you certainly need your PRP or BMAC to get to the area that it needs to go to. So we could do that in office very easily with an ultrasound. This is one of our first patients that we started PRP, and it had a wonderful response and started our practice interest into this technology. Next slide. This is a video. Now we're in surgery here. And for those that are squeamish, you may want to turn to the side here. But this is a video of the use of PRP in a repaired rotator cuff. We saw the vascularity issues. We saw that there's poor blood flow. We need healing. And so this is the addition of PRP platelets into that tissue in hopes of facilitating healing. Blood is everything. You cut your skin and it bleeds and it heals. So we're adding that to this rotator cuff tissue. These are two papers that show one in 2020, one in 2019, so very recent. They're meta-analysis, which shows that it's a paper combining other papers, both of which endorse the use of PRP for shoulders. In fact, one article combined a total of 1,100 patients and showed a significantly increased rate of healing of the rotator cuff after surgery. Next slide. In addition to the shoulder facilitated healing, there's epicondylitis. This is a tennis elbow, golfer's elbow. This is something that plagues our athletes. And these athletes, they're not 20, they're not 30, they're usually 50, 60. This is a degenerative problem. This isn't an itis as much as it is an opathy, a degeneration or sick tendon, and almost similar to partial rotator cuff tears. And so why do we keep treating something that's not an itis with a cortisone injection, which is an anti-inflammatory? And here lies PRP. And these are two studies, on the left with lateral epicondylitis, on the right with medial epicondylitis, which utilized PRP and assessed whether the rates of progression to surgery, and actually found that the use of PRP can avoid surgery in a significant number of patients. This brought to the attention this is an option again to maximize our conservative treatment with these patients through evidence-based medicine, which we always try to use. We are not a clinic that only specializes in stem cells and advertises for it on websites. We are a surgical practice that offers this technology in hopes of avoiding surgery and regenerating, allow the body to heal itself. When we started, again, back to the roots of when we started the PRP program at BSSC, to prove to us that it was beneficial to our patients, we conducted a survey. I handed all my patients a survey 8 weeks after their PRP injection. It was for the knee, shoulder, and elbow. Did the treatment decrease your pain? Did you notice an increase in functional ability? Would you recommend the treatment to a friend? If you paid for PRP, was it worth the expense? And how long did it take the treatment to take effect? And if we put together these numbers, it showed that there was an overwhelming benefit to the use of biologics in our patients. Not everybody responded, just like not everybody responds to surgery. The human is complex in that sense. But clearly overwhelming gave us these numbers and this option to use it and develop this program for PRP BMAC. Now, next slide.
All right, excellent, Jason. Thank you very much. Appreciate the insight. So I'm going to start by addressing some of the questions in the chat. These are the frequently asked questions that we hear both in the office from our patients, obviously talking through the different procedures and the different both pros and cons of proceeding with a regenerative medicine procedure as opposed to a surgical procedure. So I'm going to tackle some of these initially, and then we'll get to your individual questions after that. So number one, and Christine did touch on this a little while ago, in general, the procedures are not that painful. The stem cell harvest from the iliac crest, again, is relatively well tolerated. It's a small incision. Again, it's a relatively minimally invasive technique. PRP injections are, again, simply a blood draw like we've all had in the past, followed by an injection on an ultrasound, which means we can specifically target where we want to put the injection, which makes it less painful overall. In general, you will be awake for the PRP injection. Again, that's something that we do in the office. There's no sedation or anesthesia needed. I think in most cases, myself and Dr. Mithofer, if we're doing bone marrow aspiration in the OR, then certainly you'd be asleep as part of the surgical procedure for that. However, like Christine said, we are transitioning hopefully to be doing some of these types of procedures in the office. And we'll obviously make sure that they are comfortable as well. In terms of how many treatments, that certainly depends on the pathology that we're treating. In my patients, I counsel them that we always start with one injection and see how that responds at about 3 months, and then decide if another injection would be beneficial. Certainly people have improved and really had a significant amount of relief with a single injection. Some people, depending on their degree of pathology or their diagnosis, may benefit from other additional injections as well. So that's certainly a discussion between the patient and their surgeon in terms of what their expectations are and what their goals are in terms of functional relief. In general, if say a PRP or a bone marrow aspirate concentrate injection fails, the patient still has pain, it does not burn any bridges with respect to a surgery. Again, these injections are very beneficial. They do encourage healing, Jason had mentioned. They're using the body's own sort of healing factors and regenerative responses. But again, if they do fail, then the patient is still a candidate for surgery, as it may be more something functional or that needs to be repaired in a surgical way, such as the meniscus that Dr. Mithofer mentioned, or an Achilles tendon tear in some of my patients. In general, the results take a few months to fully experience. Again, I counsel my patients to wait at least 3 months before making any other additional decisions in terms of other treatments or additional treatments. I think in general, the recovery is slow but gradual, but it should be a general improvement along that whole course of treatment. Again, in my practice, these are coupled with physical therapy and bracing and other ways to further rehabilitate the injury or the diagnosis. And that does take time to fully implement the effects. The biggest question I think I've seen coming through the chat is whether insurance covers these treatments. And the short answer to that is, in general, no. The PRP treatments are not covered by insurance, whether they're done in the office or in the operating room. In terms of the bone marrow aspirate concentrate, those are sometimes covered by insurances if they're done in the operating room. But in general, these treatments are not covered by insurance as a whole. Therefore, it's a discussion between the patient and their provider regarding the overall risks and benefits of these procedures, of which the risks are relatively minimal. I will say that obviously the cost of these procedures does come into play, but in some cases may be more cost effective than having a surgical procedure, because then there are hospital fees and anesthesia fees that may make that treatment even more expensive on the back end. So generally, my thought process is if this treatment can be more beneficial and keep a patient from having a surgery, I think that's a better overall outcome for the patient overall. Now, the next slide, please. So if you have any further questions, obviously I've seen a lot of questions in the chat. We will get to those today as well. But please feel free to reach out to one of us as a surgeon or one of the PAs who you may know in the practice. If you have further questions about a specific condition, or want to schedule a consultation in some way, certainly call us at one of our numbers. We've now established a regenerative medicine email address that you can email us directly, and one of either the PAs or the surgeons will get back to you. And obviously a lot of this information is found on our website as well. I can answer some of the other questions that you have. So this concludes the formal portion of our webinar this evening. I'm thankful again that everyone was able to make it. This is an outstanding turnout. I think one of the best we've ever had for this type of webinar. We will definitely spend some time answering some questions. So if people are willing to stay, then we'll stay and answer some of the questions. But otherwise, have a great night, and we hope to see you in the office soon. Okay, Christine, let's have some questions. Or Jessica, I guess if you have questions, that's fine too.
Okay, sorry about that. I was on mute. Okay, so we have a lot of questions here. So I'm going to try to combine a few, just so more of a discussion than just a single question. But one of the first questions we got was, where is the bone marrow harvested? And I believe we've touched on that a couple different places, but you all typically go to the posterior iliac crest or the backside of the pelvic bone, correct, Dr. Hoffman?
So I'll take it from either anterior or posterior. For me, it depends on patient positioning,
Okay.
whether they're supine or prone for their procedure. Obviously, a lot of the procedures I do on the Achilles and posterior ankle, they're prone, but I'm comfortable taking it from either side of the iliac crest. We know from previous research is that the iliac crest has the highest concentration of stem cells. And therefore, that's why I usually choose that as my site. But again, they are able to be taken from other bony areas as well, like the tibia or the calcaneus.
Okay, and then the other question around that is who in the practice will do the actual harvest?
That's a great question. So in general, I think for PRP injections, most of the blood draws are done either by the surgeon or by the PA. In the operating room, the surgeon does the harvesting, in my experience, almost entirely.
Okay, and then a lot of the questions are centering around post-injection protocols in terms of, are you immobilizing joints? How soon can they walk? Do you recommend physical therapy? Those types of questions.
Okay, so I'll answer from my world, which again is the world of foot and ankle surgery. Almost universally, the patients are mobilized after their injection, either in a postoperative shoe or a fracture boot of some kind. Almost universally, patients can walk right after their injection. They're usually immobilized for a week or two as they get through the initial inflammatory phase of the injection, at which point they start physical therapy. And then physical therapy can last 1 to 2 months, depending on their condition and their diagnosis and what result we're looking for. Jason, how about you?
Can you repeat the question?
Post-injection protocols in terms of joint mobilization, immobilization, movement, physical therapy, et cetera.
Absolutely. We do add physical therapy to PRP when it's needed. If we do the PRP injection, there's posture deficits or weakness, we'll add it along because it is it is nice to do to treat to solve the problem. So now you're not just doing PRP, you're adding strengthening, adding posture work. We add it onto that as needed. PRP in and of itself, I tell patients we treat it as an acute injury. We take a chronic problem, treat it as an acute injury, and the body can heal an acute injury. So I tell them to really go easy on it, protect it, and slowly progress. The shoulders, they progress their range of motion as the days go on. We avoid nonsteroidals. We take Tylenol afterwards if it's uncomfortable and ice. But oftentimes you see some imbalances when you evaluate the patient. That therapy can be handy. We use PRP really as a combination treatment with other modalities.
Dr. Mithofer, did you have any different comments for your post-injection protocols? Jessica, maybe unmute all the presenters here. There we go.
No, it's that. Thank you. Yeah, so I think you want to look at the general situation. I think you can't make a general statement. I think that what
Right.
Jason was saying, every patient is a little bit different, and I think you try to manage every patient post-injection differently. The same question is who's going to get PRP, who's going to get BMAC. I think the key is to look at all the factors and then make the decision in conjunction with the patient. Look at the anatomy, look at the function that the patient wants to achieve, how soon do they want to achieve it. And then I think communicate with the patient, but also communicate with the physical therapist afterwards to really optimize the rehabilitation and recovery from the injections.
Excellent. Okay. Jessica, can you keep that contact info up for us on the by sharing the screen if you don't mind? All right, Christine, what's next?
Yes, and there's a lot of questions regarding soft tissue injuries and if you treat them, such as abductor gluteus or torn abductor and gluteus medius, different tendon ligaments, yeah, and some of the smaller joints like in the hand and the thumb.
Sure. So I think that plays a similar role in terms of the soft tissue injuries around the ankle and foot. We have Dr. Wurz, who's our hip preservation specialist here, and I think he deals a lot with the adductor and gluteus tears. Certainly, the majority of soft tissue injuries can be treated in the similar manner that we've discussed this evening. And that, again, can be either PRP or stem cell treatments, depending on provider preference and what the additional pathology is. But in my mind, yes, there's a lot of overlap between the hand and the foot, certainly, but also some of the larger muscle groups in the body.
Okay, great. There is some question around post-surgical. So patients that have scar tissue formation post knee replacement surgery or any other types of surgery, is it still okay? Or maybe they've had an ACL repair. So is it okay to still treat these potentially pain or scar tissue conditions with an injection after surgery?
Yeah, it's there's many reasons why someone would have scar tissue or someone would struggle after surgery. Certainly, that needs to be evaluated. But PRP, in terms of facilitating healing in certain areas around a surgical site, is certainly indicated. And in reference to the soft tissue question, we on hamstring tears, proximal hamstring tendonitis, tendinopathy, we're using PRP. So any soft tissue or tendonitis, tendinopathy is an indication. That answers both of those questions there.
And then one of the questions is, are there any contraindications to using either PRP or concentrated bone marrow aspirate, and or are there any side effects?
So that's an excellent question on both sides. In my opinion, there are no real contraindications other than active infection or active chemotherapy. I think those would both be contraindications to proceeding with a biologic injection, because obviously, again, we're taking your own stem cells and no blood, so you want that to be as primed as possible. From a side effect standpoint, I have not seen any significant side effects from any of these injections. Certainly, there's always a risk of infection, which is relatively minimal, but that's true for any type of injection or any type of procedure. I will say that, again, I can't counsel my patients specifically about the inflammatory phase afterwards, because that certainly is painful. I don't consider that a side effect. I consider that an intended effect of the treatment, just like Jason had described earlier. But it's important to counsel the patients so that they know what to expect, especially for those first week or two afterwards, so they're not overly concerned that something might be wrong.
Okay, very good. Another question, a couple of questions around what your fees are for these injections for both PRP and bone marrow, and how many of some of these patients are hearing from other physicians that it typically takes a series of 2, 3, 4 PRP injections to get a result. And so they're wondering what the fee is. And I don't know if you want to discuss that now, or if it would be better just to schedule a consult.
Sure. So I would answer that as there's certainly an individual nature to each of these injections. I think each individual provider has a different fee schedule or cost of procedure for this type of work. Certainly that depends on what we're injecting and how much we're injecting and those concepts as well. And again, it also depends on the type of pathology. I will say in general that my patients do not receive an extra charge or extra fee for the stem cells that we draw in the operating room. This is a fee that's covered by the hospital in most cases. But again, I would counsel them to contact their surgeon, their provider, and have that discussion as part of their consultation, not only to discuss the fees, obviously, but also to discuss the pathology, the treatment options, and whether PRP or bone marrow would be an appropriate treatment for them initially.
Okay, and another question, would somebody who is obese potentially be a candidate for this type of regenerative treatment?
Again, I would say that yes, that's certainly a possibility. I don't see any contraindication in that respect. In terms of that question, I think some of the harvesting sites may be a bit more of a challenge, but certainly they have similar stem cells to anybody else that's some of our patients are on the webinar. So I don't see that as a contraindication in my practice.
Very good. And is there an age limit in your practice as to who you would treat, or when is there a cutoff in terms of age for treatment?
Generally, no. I would say there's arthritis is a good example. Arthritis goes until highest age, and it's more the degree of arthritis. So if you have somebody who's in their 80s and has degenerative changes that are starting to become a problem, I think it's very reasonable to consider that as an option and not so much look at the age, but more as the severity of the condition and whether that might benefit from the injection.
Okay.
I'll piggyback on that, Christine, just for a second. The beauties of my practice is I see anybody from teenagers to the octogenarians. So I see the whole gamut of patients in terms of age ranges. I see also obviously multiple different pathologies within those age ranges. Some are more common in younger patients, some are more common in older patients. I've seen a few questions about bone-on-bone arthritis as well. So I'm going to shift gears to that just a little bit. Obviously, I take care of a lot of ankle arthritis. We do a lot of surgery in that respect, whether it's ankle replacements or ankle fusions. But I would say the patients who have presented with early or mild to moderate arthritis of the ankle have been successfully treated with some of these biologic injections, whether it's PRP or stem cells. And again, I think that applies across the board to shoulder arthritis and knee arthritis as well. Certainly, it's not a treatment procedure or treatment of choice for somebody that has bone-on-bone arthritis. I think, like Dr. Midhofer eloquently said, that the ship has kind of sailed in that respect, because once you get significant cartilage damage, we really don't have a way of regrowing that. So any sort of significant causal defects, any sort of, again, significant arthritis is not well treated with one of these injections alone. However, there are certainly treatment procedures that usually involve the surgical procedure where stem cells and the scaffold and maybe PRP would be beneficial to healing some of these things in an earlier stage. So in my opinion, there's certainly a role for biologics really throughout the gamut of orthopedics. And that, again, does include symptoms of arthritis as well.
Good. A couple of specifics for you, Dr. Hoffman. Would patients potentially be a candidate for a treatment like this after a post reconstruction of the ankle from a traumatic injury that is going to leave that patient with some stiffness and potential chronic pain? And also they're asking about a Liz Franck fracture.
Sure, good. So those are both good questions. So yeah, as Jason alluded to previously, certainly scar tissue has multiple etiologies. I think most commonly in my world, it tends to be post-traumatic. And I've certainly had some success with these types of injections in treating those types of conditions where, again, as far as we can tell, the fracture is healed, the cartilage seems to be okay, and they're dealing with a scar tissue problem. So having this sort of healing and regenerative type of injection can be useful in terms of treating some of those post-traumatic type of conditions. In terms of Liz Franck injuries, that's a little bit more of a difficult subject. I think in my world, the common thinking is that if patients have a complete Liz Franck ligament rupture, that's better treated with surgery. And the reason for that is there's usually some incongruity of the joints associated with that ligament rupture. And once there's some incongruity of the joints, that may lead to arthritis, and that's a problem that is usually better fixed surgically. However, there are certainly patients that have Liz Franck ligament sprains and midfoot sprains and partial ligament tears. And again, I think this is the perfect episode of care for that type of injury as you're instituting some biologic healing. Again, the ligament is not completely torn. There's no articular incongruity. Therefore, the ligament has a better chance of healing with, again, appropriate immobilization and physical therapy after that. So there certainly is a role for these types of injections in that specific case.
Okay, very good. Around soft tissue injuries, and this is really for any of you, what would be the best timing in relation to when the injury happened to have an injection like this? Would you suggest to wait would you want to do it immediately when it's very acute, or would you wait a couple of weeks? I guess they're just asking about timing.
Yeah, that's a good question. In my practice, I would wait. I would wait because at the initial injury, the body almost produces its own PRP as its own healing response. And I would wait you can go as early as 2 to 3 weeks after the body's inflammatory process has resolved and you want to reinvigorate another healing response. So I would give the body time to respond to that injury naturally.
Okay. Go ahead.
I agree, totally agree.
Yeah, and I think that like the rotator cuff, for example, is a good example. You can have an acute rotator cuff tear or a small partial rotator cuff tear. You got to wait, you got to let it, potentially heal by itself. Same thing for a ligament injury around the knee, like a medial collateral ligament injury. You let it heal. There's oftentimes a very good healing response. And if it's continuing to be a problem, particularly for the deeper portions of the MCL, that might be a good option where you can do a guided injection that can facilitate and augment the healing process that the body already is engaged in.
Okay, and I think this will probably be the last question. I think we've covered most everything here. What is the difference between PRP and prolotherapy?
Prolotherapy is the use of, let's say, sugar water or a noxious substance to kind of instigate an inflammatory process to encourage healing. We don't perform that in our practice. I have some patients that have seen a doctor in Boston for it and have had a good experience. I've seen patients that have not had a good experience in terms of outcome. It's just a different philosophy in terms of healing and the use of the body's ability to heal or pushing the body towards an inflammatory process to encourage healing. So just a different mechanism in hopes of getting the body to heal itself. There was another question about full thickness rotator cuff tears. I saw it come over a few times. It's important that I think we answer that just because if they're for partial tears, I've seen PRP change people's lives in terms of shoulder pain. Full thickness tears that are surgically repairable should be repaired. So that's one region where I don't think PRP or stem cells can provide an overwhelming benefit. So once that rotator cuff is torn off the bone, that should be put back to the bone and can be made worse with time. So if you do have a cuff tear, you should definitely seek an orthopedic opinion.
Okay, and I guess one last question as I'm going through them again, they keep coming in. If this is so effective, why isn't insurance covering it?
That's a really good question. Probably we're three different people. You may want to ask three other people, executives maybe, on why they're not covering it. I think, in my opinion, and Dr. Mithoff or Dr. Hoffman may share this, is that eventually they will. I think that we need to do a better job in doing more research and showing how this stuff has changed people's lives. And once that's done, eventually the insurance companies will come around.
Yeah, I think one thing that's important also is that the insurance companies in general require very high level studies. They require time to be done because they need to be set up and performed in a certain way, and that its statistics really show a significance of the effect. And to do that properly, that takes time to set up and then conduct. I think for the knee, I can say, as I mentioned in my part of the presentation, that there's a significant amount of information about the knee osteoarthritis already. There's for PRP, increasingly for the BMAC or stem cell treatment as well. I think it's just a matter of time. I think the insurance companies are looking for a certain level of evidence. I think if you want to wait for the insurance companies, that's up to you. But I think the key is to see that there is, if you look carefully through it, and I think if you look in the medical literature, there's plenty of evidence of that this works. And again, the evidence is accumulating over time. And I think that as the evidence gets higher and higher level and larger, I think the insurance companies will pick it up. And I know for the knee, for example, for knee osteoarthritis, there is discussions with insurance companies all in process to make that happen at some point. So we'll see.
And I'll just piggyback on that. There's such a diverse amount of conditions that we treat with these injections. I mean, we've talked about 30 different types of diagnoses and problems that patients present with. It's hard to present evidence for every single one of those at the same time. So until we get a larger body of work, like Dr. Mithoff was saying, it may be a challenge to get this approved by the insurance companies, because again, they're looking for a higher level of evidence. However, obviously people that are doing a lot of these, as we are in practice, have seen excellent outcomes. And you can see by Jason's last slide there from before that people are universally better off from a pain standpoint, better off functionally, and happy with the procedures.
And this may or may not be something that you all can speak to. I know you don't address spine issues, but we've got a lot of questions regarding the effectiveness of these types of injections for degenerating disc and facet arthropathy. I don't know if any of you want to speak to that. I know I mentioned my experience with my neck, but if any of you want to speak to that, go ahead. But there was a lot of questions about it.
Yeah, I don't think any of us has really experience with that personally, and I don't think that's something that we're involved in as a practice, but there's certainly providers that are offering this, and there can be certainly use and successful use of this. So I would reach out to the spine providers to discuss that. It's certainly very feasible.
I would agree. Just from my experience in the regenerative space, this is a very popular application right now that is being studied currently. So it's fairly new. It's being studied. We don't have a lot of data currently on the spine per se, but there are several people in the spine world, several physicians in the spine world, either neurosurgeons or orthopedic spine surgeons, who are beginning to do some of these procedures with success. So again, it's fairly new compared to all the other applications that we discussed tonight. I think that's it. Oh, somebody asked about if they have abnormal plasma, and I'm not quite sure what that means, what an abnormal plasma condition would be. And so would that potentially be a contraindication?
Potentially. If I ran into that situation, I'd probably refer them back to their oncologist and see in terms of platelet function, or get some advice in terms of their particular blood disease.
Agree. And I just saw she just posted it was multiple myeloma. So that does make sense.
Yeah.
Right. Mm-hmm. Yeah, because we're basing our treatments based on the patient's own factors. So if those are not adequate, then the treatment is less likely to be successful.
Correct. Okay. All right.
Okay. Terrific. So again, I just want to thank everyone for attending. I want to thank our panelists for participating. I think we had a great time, obviously making this presentation, making this webinar, delivering it to you. I hope everyone learned a lot who was on the call. I apologize for some of the initial technical difficulties, but this is the world that we live in, so we'll get through it. The webinar will be posted at least to the Boston SSC website. I know some people had wanted an email to them as well, so it obviously will be posted online for access. Certainly, friends, family members, if anybody else is interested in the technology generally in the regenerative medicine space, feel free to reach out through one of the methods that you see on the screen there. And again, we're all happy to talk more in detail or send you over to one of our other providers for a consultation who may be able to better answer your questions.
Thank you, everyone.
All right. Have a great night.